treatment, and management. All right, next slide, please. Some webinar tips before we proceed. So participants will be in listening mode and will not be able to ask questions verbally, but you may enter questions in the chat, and we will have a Q&A session after the initial presentations, and we'll try to get through as many questions as we can as time permits. And just to let you know, the slides and a recording of today's webinar will be available on the NIMHD website. Next slide, please. So today's agenda will start with giving you all a background of the RFA and the objectives. And then I'm going to hand it over to Jennifer for some information about applications. Then we're going to switch to my colleague, Professor Lode Sharp, who's going to talk about the peer review of the applications. Then we'll go into a brief informational session about the timeline for the submission, review, and the selection of applications. And then we'll have time for some participant questions. Next slide, please. All right, so about the RFA background and objectives. Next slide. All right, so significant disparities persist in the incidence, morbidity, and mortality of chronic diseases. You all know that. And so it's pretty difficult to try to reconcile and address the complex drivers of chronic disease health disparities. And there are a lot of requirements to try to do that. First, a transdisciplinary framework that cuts across scientific and organizational silos, we've heard that term before, to integrate multiple disciplines and community engaged methods. In addition, strong collaborations between researchers, community organizations, clinicians, and healthcare systems, public health agencies, policymakers, and other stakeholders. In addition, research conducted at a regional level, provides the opportunity to develop local coalitions of relevant stakeholders to address place-based determinants of health. Next slide, please. So before I go on, just so everybody's on the same page, I'd like to briefly go through key definitions. And these definitions, of course, are on the RFA webpage. So chronic diseases. So we're speaking about conditions that last 1 year or more and require ongoing medical attention because they're not curable and often affect quality of life and limit ADLs, activities of daily living. What do we mean by populations with health disparities? So as you all know probably already, that NIH has designated health disparity populations. So those include the racial ethnic populations, Blacks, African Americans, Hispanic Latinos, American Indians, Alaska Natives, Asian Americans, Native Hawaiians, and other Pacific Islanders. In addition, we consider socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minorities as all part of populations with health disparities. And what do we mean when we say region? So we define a region as a geographic area that may encompass a single state or US territory, multiple states or multiple US territories, or areas within a state comprised of 2 or more counties that share some commonalities. For example, common patterns of health disparities, common determinants of health, common policy or service landscapes, or any other relevant common factors that may apply. And key point here, by region, we're not talking about an area merely where the center investigators are located. Next slide, please. So objectives. To support regional comprehensive research centers on the prevention, treatment and management of chronic diseases associated with health disparities. So chronic diseases of specific interest include, but are not limited to, the following: obesity, diabetes, hypertension, coronary disease, congestive heart failure, CHF, asthma, chronic kidney disease, chronic liver disease, stroke, osteoarthritis, and certain cancers. Next slide, please. And let's go to the areas of specific interest. So really interested in interventions that are tested or evaluated across the entire region, rather than a single location within that region. And please apply the definition of a region that we just went over. Interventions that reduce disparities in the incidence, morbidity, or mortality of co-occurrent chronic health conditions, and we just spoke about those conditions of interest. Interventions that reduce multiple common risk factors for multiple chronic diseases. Interventions that address multi-generational transmission of chronic disease risk and protective factors. Interventions that address structural racism and discrimination as a determinant of health disparities in developing and managing chronic diseases. And interventions that reduce preventable hospital admissions or ER visits related to chronic health conditions. Multi-sectoral interventions that involve collaboration across different types of organizations in the public and private sectors are of interest. And also multi-level and multi-component interventions that reduce disparities related to access to and quality healthcare services to chronic health conditions. Next slide, please. Okay, so I'm going to hand it over to Dr. Alvidrez, who will speak to you about the application information.
Hi, everyone. Thank you. My name is Jennifer Alvidrez, and I will talk about application information. Next slide, please. So some of the requirements or expectations for the center. So the centers must address 2 or more chronic conditions that commonly co-occur and or share common social contacts, etiological pathways, or risk factors, and may share some similar management strategies. Centers must identify a specific region of focus and are expected to provide a convincing rationale for why the selected geographic areas reflect a coherent region. As the RFA specifies, it's generally expected that the region will be made up of contiguous areas. There may be exceptions, particularly related to work done with tribal populations or the US territories where contiguity is not possible, but either way, we will be looking for a rationale for the selection of the region and why it's a region. Another requirement, there must be investigators from at least 2 academic or research institutions and a coalition of relevant stakeholders within the region. Of course, the centers must include all required center components, and there will be a coordinating center that's attached to this initiative. And so all the center awardees will be expected to work with that coordinating center. Next slide, please. And I realize I didn't start my video, so here you go. Okay, so the cores and components. So the administrative core is pretty standard as administrative cores go. It will provide overall project oversight and evaluation. It'll evaluate the performance and progress of the center. And it does include a data component because of the expectation to harmonize and share data across the different components and projects of the center. as well as with the coordinating center. Next slide, please. The Investigator Development Core is to support a pilot project program for postdocs, early career faculty, and other early stage investigators as NIH defines early stage investigators. The pilot projects, of course, will be focused on the theme of the center related to chronic disease disparities. Pilot awardees should include scholars from backgrounds underrepresented in the biomedical research workforce, and scholars should be from within the region. So either the applicant institution or collaborating institutions or other researchers from organizations within the region. The pilot projects are expected to range from $25,000 to $50,000 direct costs per year. They can last 1 to 2 years or more, I suppose, if you want. But there needs to be a minimum of 6 new pilot projects supported each year. Next slide, please. The Community Engagement Core will really serve as the focal point for managing the coalition, for nurturing the collaborations, for bi-directional working relationships with consortium partners, to identify priorities and community needs, and develop and disseminate relevant information to stakeholders. Next slide, please. There are 3 required research projects, so there are no more and no fewer than 3. So there need to be 3 research projects. These are really R01 level projects, so fully powered, hypothesis driven, the usual expectations for an R01 project that address the research questions relevant to the center's focus. So the projects all need to have an intervention focus. So that could be prospective testing or new or adapted interventions, or testing of implementation strategies of evidence-based interventions or practices, or evaluations of existing interventions that are currently implemented by service providers within the region. At least one of the projects must be a clinical trial. And across all the research projects, there is the expectation that there will be a transdisciplinary, multi-level, multi-domain perspective, a la the NIMHD research framework that is linked in the RFA, and engage relevant stakeholders within the region. Next slide, please. So the research projects are limited to budgets of $500,000 direct costs annually each, not including consortia F&A. And there should be synergy between the research projects so that there's sort of the sum is greater than its parts, and not that the research projects are completely independent from one another. Examples of synergy include, but not limited to, pooling of data across studies, sharing of research materials, resources, tools, data analytic strategies, testing different components of the same conceptual or theoretical model. Research projects that are not a priority or non-responsive are planning studies like R21 or R34 level studies where the intervention may not be specified and it'll be determined over the course of the project. We're really looking for fully specified shovel-ready studies like one would expect for an R01, and drug and device trials and animal studies are non-responsive. Next slide, please. So that is my component for now. I will now turn it over to Marilyn Lodd-Sharp to talk about peer review.
Good afternoon. I hope you're hearing me. Let me turn on my video also. Hi. Good afternoon, everyone. So the peer review of the application, please, next slide. So the preparation for review. We will follow the 4 specific characteristics. what is the goal of the program, the review criteria that are specific to this fora, and also the criteria of clinical trial. They will have additional review criteria, the study timeline and human subject and inclusion. Next slide. Okay. Administrative review of the application. So we will follow the RFA requirement, and we will search for the needed expertise. Next slide. So the selection of the reviewer will be by scientific expertise as defined in the form, and also as the collective content of all the applications. We will be very well aware and do very good attention to the conflict of interest. And we want to have a diverse representation for gender, demographics, and also geography. So the review process will have a pre-meeting a written opinion and an overall impact preliminary score, and we will have a resume that will be done in 30 days after the review meeting. Next slide. So the reviewer will evaluate each of the application through the overall, and will give a preliminary score with the 5 criteria: significance, investigator, innovation, approach, environment. It will have, like it was already talked about, an administrative core, investigator development core, community engagement core, and this 3 core will receive only 1 score, and the research project, so the three research project, each with also the 5 criteria. Next slide. So the overall, each criterion will receive a score, and the reviewer will provide an overall impact score to reflect their assessment of the likelihood for the center to exert a sustained, powerful influence on the research field that is involved, in consideration of the review criteria, and also additional review criteria. For each of the core, the reviewer will provide, like I say, only 1 impact score to reflect their assessment also of the likelihood for the core to exert a sustained, powerful influence on the research field. 3 research projects, and the reviewer will consider each of the review criteria in a determination of the scientific merit and give a separate core for each. Next slide. So since it's a clinical trial, they will have a study timeline, and they will have human subject criteria. So the protection of the human subject against the research risk. There are 5 criteria. There is also inclusion, so it's sex, gender, also individual of all age, and minorities. There are other criteria like biohazard that are also included in these review criteria. That these criteria are included in a determination of the overall score. Next slide, please. There are additional review consideration. These criteria are not included in a determination of the overall score, but we ask the reviewer to have a look at it. So other implication information, which is assessed but not included in a determination of the impact score, are the selected agent research, the resource sharing plan, the budget and period of support, and the authentication of key biological or chemical resources. Next slide. So for the peer review meeting, the day of the meeting, some application may be streamlined, which means not discussed. So the application may undergo a selection process in which only those applications deemed to have the highest scientific and technical merit, so generally the top half of the application under review, will be discussed and assigned an overall impact score. The final impact score is based on an average of all the voting reviewers. It's multiplied by 10. A score of 10 is exceptional to a score of 90, which is poor. And a summary statement for all applications will be available approximately 30 days after the review meeting. We really ask you to please do not contact the member of the review panel. Next slide, please. These video are just educational, and you're welcome to use them to have more information on the peer review. Next slide. I think I'm going to pass it on now, pass it on back to Dr. Alvidrez.
All right, thanks, Marilyn. Next slide, please. Okay, so a quick review of the timeline. Next slide, please. So, and this is all in the RFA, of course. Letters of intent are due May 8th. Application due date is June 10th. Note that you can see this is a very compressed timeline, so late applications will not be accepted. For this initiative, the peer review will take place in July, the council in August, and then the earliest start date is September. So these awards are intended for fiscal year 2021. So it's expected the awards would be made in September. Next slide, please. So as Marilyn indicated, if you have any questions as you're going through, please contact us. Email is usually the best way to get a hold of us. And in particular, if you have budget or financial related questions, to contact Priscilla Grant, and it can be helpful to have your contracts and grants or your business official be the one to make that contact, just to make sure that the questions are crystal clear about budget or grants policy. Next slide, please. So we will now take your questions. So I think we're going to, you can put your questions in the chat. We have some questions that have been sent via email. So if we can have Fabienne be unmuted, and then the two of us can just stay unmuted while we do the Q&A session.
All right, thank you, Jennifer. Okay, so as Jennifer mentioned, we did receive some questions in advance. So I'd like to maybe go through a couple of them. I'm already seeing some questions coming through the chat, but let's just start with the first one. So the RFA doesn't explicitly include mental illness and substance abuse / addictive disorders. Are they included as part of the chronic diseases or as a chronic disease within the FOA?
Right. Yes, they can be included as chronic diseases in this initiative. However, the chronic conditions that are listed in the RFA really are the priority conditions. So if you wanted to add additional ones, chronic conditions, in addition to 2 or more of those listed, that would probably be the best strategy.
Okay, thanks, Jennifer. I'm going to do, I guess, one more from the previously sent in questions. Another question was, should all projects focus on the same chronic diseases, or is it okay if they focus on different diseases?
Right. So we are leaving it flexible about what the projects are about as long as they're consistent with the theme. So it is important to remember that the goal of this initiative or the impetus was the siloed approach to chronic disease across NIH and in general, rather than looking at chronic diseases as they co-occur or the common risk factors for multiple chronic diseases. So that's the overall theme that we're expecting from the center. So we do expect the individual research projects to be reflective of that theme. So you would need to think about, if the goal is to sort of unsilo chronic disease disparities research, if your research projects fall within the spirit of the initiative.
Okay, thank you. One easy question from the chat. Yes, a copy of the presentation will be available on the NIMHD website. Let's see, another question from the chat. This looks like a question that was similar to what was written in previously. So would, let's see, it refers to the 6 pilots. Let's see, for the initial proposal, are we expected to have 6 pilots already identified?
So this is specified in the RFA. We don't want to see pilot projects specified because the goal is to offer a pilot project program where the pilot projects are solicited once the center is awarded. So what we're looking for in that section is a description of the process to establish and maintain a pilot project program, not specific projects that are already identified.
Okay, another question refers to the regional requirement. Do all 3 projects have to have a regional component? I think the answer to that is probably yes, but
all the projects need to fall within the region that is specified. We identified as an area of special interest projects that to have the research projects that span the region rather than just being located in a single site within a region. So it's not a requirement, but it is a preference that we have, or a priority that we have.
Okay, thanks. I'm trying to look for questions that, let's see. Oh, okay, this is interesting. Could you please discuss more about the PI structure? I'm assuming that a multiple PI structure is acceptable given the coordination between 2 academic institutions. Is that correct?
That's correct.
Okay.
It's not a requirement, but we are expecting to see a lot of multiple PI applications coming through.
Another question is about chronic diseases, chronic conditions. Are there chronic conditions that would not be considered responsive? For example, cognitive impairments. Oh, this is similar to the previous question, but for example, cognitive impairments due to other chronic diseases, stroke, for example, stroke or cancer.
Right. So the issue is probably not responsiveness, which makes your application get kicked out, withdrawn, and doesn't even go through review if it's non-responsive. We do have the chronic conditions that are listed are really a priority, and other conditions can be added on top of 2 or more of those listed conditions to be a priority for this initiative.
Okay. Let's see. This question is about the cross-institutional collaborations. Can you please talk more about the cross-institutional collaborations? Are there suggested structures for that? And how would different institutions be defined?
So I'm not sure of the meaning of the last part of the question of how would different institutions be defined? If that question, well, if you can clarify what your question is in the chat, that would be helpful. We really are leaving it up to the applicants to decide how to structure. There can only be one applicant organization. So even if there are organizations or institutions working in partnership, one of the institutions needs to be the applicant organization, and the rest will be collaborating organizations or institutions. How the responsibilities are divvied up about which cores go where, we're really leaving that up to the applicants.
Okay. This question is about the pilot projects. Are the pilot projects subject to the data harmonization and data sharing requirements?
Right, so there's two components. One is within the center. So we would like to see how there will be synergy across all the research activities going on in the center. So to the extent, and we recognize there are different kinds of studies and different research questions, but to the extent that having common data elements within the projects, both the research projects and the pilot projects is possible, we do like to see that. And then there are the kind of harmonization and data sharing requirements from the coordinating center, and those will really be hashed out once the awards are made and once a coordinating center is established. So the answer is there aren't requirements at this point that are established, but there is the hope that there will be some shared data elements across the different research projects in the center.
Okay. Let's see. This is a question about outcomes, interesting one. If the research project is using implementation science, is it okay if the outcomes are implementation outcomes rather than clinical outcomes?
Right. So this is more about what would be a priority than what is a requirement. I think it really depends on the topic and how much the evidence-based interventions or practices have been shown to be effective in the particular populations that are included in the study. In some cases, there may be agreement that an intervention works, like a COVID vaccine, for example, that can be your outcome rather than seeing whether the COVID vaccine prevented COVID infection or hospitalization or death, for example. There may be interventions that really haven't been tested on some of the populations of interest here. And so then there might be, it might be beneficial to include those health outcomes as well. So I think it really depends on the nature of the question, the actual evidence-based interventions or practices, and the population.
Okay, let's see here. A question about the cores. Is the investigator core more of a pilot core or more of a mentoring core?
The investigative development core is primarily to support a pilot project program. So there would be the expectation that there would be mentorship provided to either the pilot project applicants and awardees. There's not the expectation that there will be general mentorship outside of that provided in the pilot project program.
Let's see. We got a couple of questions about the centers and affiliated. So one of them is, could the two academic research institutions be a university and an affiliated academic medical center? I guess it sounds like under the same university, or that's what I think this question is alluding to.
Right. So we are looking for different institutions to be the separate academic institutions.
Okay.
So in the RFA related to eligibility to submit applications, that's identified as having a unique DUNS number or an NIH IPF number. However, so that's sort of the letter of the RFA. The spirit of the RFA is sort of separate academic institutions within the region. So within the same university, different schools within the same university that may have different DUNS numbers, you can think about whether that is really adhering to the spirit of having multiple institutions involved.
Okay. This is an interesting question. So can you say more about the expectation for collaboration with existing NIH or federally funded consortia or cohorts?
Right. So the thinking there is that we would like to see applicants leverage what's going on, existing resources, existing networks, existing infrastructure without duplicating. So different regions may have different kinds of centers present. So we would just like to make sure that the investigators describe those other centers that are listed in the RFA, identify those, talk about how they may leverage or collaborate with those institutions and how they're non-duplicative of them.
Okay. Okay. Another question about the condition. So the RFA specifies obesity and diabetes are pre-diabetes and syndromes.
I don't know if you dropped off, you have a little triangle, but can you repeat that question? You're breaking up. Okay, it sounds like Fabienne is having some. Oh, are you back?
Yeah, I specify obesity and yeah, I think I might have to turn on, stop my video for a second here so I can strengthen the signal. Do you need me to repeat the question again, or it's
yes,
the RFA
please.
specifies, sure. The RFA specifies obesity and diabetes are pre-diabetes and metabolic syndromes priority conditions.
Right, so there is a distinction between risk factors and the actual health conditions. So if you are focused on more risk, you would want to specify what health conditions those risk factors are risk factors for. So I think the answer is yes, but you would want to be clear that you're not just looking at risk factors absent from the health conditions that may develop as a result of those risk factors.
Right. Okay. Let's see. Okay, so we spoke a little bit about the consortia and NIH-affiliated kind of collaboration. So this question is about non-federally funded consortia. So essentially, the question is, what about non-federally funded consortia or cohorts, i.e. regionally funded, foundation funded, or is the preference and spirit about federally funded? I guess it's that need for a collaboration with federally funded existing organizations.
Right. There are two separate issues. The desire to, so there's a desire for the NIH funded programs to really work together, leverage existing resources rather than reinventing the wheel and not have overlap. So that's the intent of really wanting to know, what's going on related to other NIH funded centers or networks. As far as having a regional coalition, we absolutely encourage collaborators from all sources and to talk about how existing programs, resources, infrastructure can be leveraged to further the goals of the center.
Okay, thanks. Let's see, we've got a couple of questions about Hep C. Does hepatitis C count as a chronic disease, even though there is a cure?
Right. So again, to say that the conditions listed in the RFA are really the priority conditions. So any number of other conditions can be examined on top of 2 or more of those conditions. So hepatitis C could count if it's sort of looked at in conjunction with 2 or more of those identified chronic conditions.
Okay. All right, I'm trying to go through earlier that I
Oh, you're breaking a little again.
may have missed. Let's see. Okay, thank you. You're very welcome. Hello.
I can, Fabienne, I see some questions about asking for some clarity about the clinical trials, so I can address that.
Okay. Okay. Go ahead.
Yeah. So clinical trial is using the NIH definition of a clinical trial, not clinical as in required to be in a clinical setting. So the NIH definition of a clinical trial is really you do a prospective something or other that's supposed to improve the health outcomes of the participants. So it could be healthcare setting based, it could be community based. It just needs to be a prospective intervention. So that could include preventive interventions, treatment interventions, self-management interventions, as long as the study itself is the one offering and delivering the intervention rather than studying interventions that are already implemented in practice.
Okay, I have another question. Let's see, that just came up. Would it be appropriate to focus on prevention of a chronic condition, as in preventing childhood obesity in a population with a very high risk of obesity?
Yes, I mean the health conditions listed, the actual research projects can be about prevention, treatment, or management.
Okay. Let's see. Are FQHCs okay as a collaborating institution?
I'm not sure if I heard the end of your question, but definitely FQHCs. There's really no limit to the types of collaborators that could potentially be included in research projects.
I'm sorry, my signal is not the best here. I think it's conking out, so I may be in and out. Did you get the question about the FQHC? Yes.
Yes.
Okay, great. Okay. Okay, let's see here. So there's a question about a region, the regional requirement. Can a region include multiple HHS regions? Also, is it required that all 3 R01s address multi-level interventions?
To address the region questions, so we're not requiring the use of the HHS regions. So the selected regions could be portions of an HHS region. They could be part of this region plus part of that region. They could span multiple regions. The idea, though, for regional is that there's some shared epidemiology, structural and social determinants, service organizations that address people living within the region. So if if your region is too big, it's no longer a region, it's more like national. So we are looking for geographic areas that make sense as a coherent region, that are going to have shared local, common local stakeholders, common patterns of chronic disease disparities, or chronic disease morbidity and mortality. So yeah, applicants just need to find the sweet spot of what region makes sense for them as they define and justify their area of focus. And there was a second part to that question. If you could repeat that, Fabienne.
Sure. Let's see, the region. And also, is it required that all 3 R01s address multi-level interventions?
So that is our preference. It's identified as an area of special interest to have multi-level interventions. So it's not something that would make an application non-responsive, but it is, multi-level interventions are a priority for this.
Okay, let's see. Question about external partners for projects. Could the external partners be embedded into each project, or have their own project, or both?
Both. The projects can be led by non-academic institutions, or can be collaborators on projects that are led by academic researchers. For each project, we are expecting to see relevant collaborators and stakeholders involved in the project.
Okay, great. Let's see, there's a question about the new other support format. Is there an expectation that the application include the new other support format? And there's a link to, I guess it's the notice OD 21073. I don't know if you are familiar with that off the top of your head. I'm afraid to click on the link and then I'll drop off the call.
So if it, I don't recall about when the policy starts.
Yeah,
so,
yeah.
Yeah,
That's an effective date question. You could always email us, I guess, after.
Right. I mean, the notice says when it gives when the policy starts related to application due dates, and whether this application due date comes before or after that would determine the response to that.
This is Nathan. It's applications after May 25th.
May 25th. Okay, great. Thank you. Thank you. All right. Let's see. Another question. If a county is large enough and diverse enough, can it be a region?
In the RFA, we kind of specify encompassing sort of multiple sites, or multiple locations, not just purely local, which you would expect to be within a single county. So I think we are looking for things that expand beyond more than one
county.
One county.
Okay. Okay, there's a little bit of a lull in the questions in the chat. If anybody has any additional questions, please let us know. I think we address most of the question. Oh, okay, there's one question that was previously sent in. So if there are key personnel involved with all of the R01s, for example, a biostatistician, might that person receive salary support as part of the admin core? That may be a grant management question, I don't know.
Right, yeah, there is flexibility if in how the budgets and the key personnel are structured. Because there is kind of a data component to the admin core, excuse me, and there aren't, excuse me, and there aren't, there's no methods core, there's no biostatistics core, for example, the way there are in some centers. So some of that technical work could be included in the admin core, or the separate contribution can be identified in the individual research projects. It's really up to the applicant to decide the best way to divvy that up.
Okay. Another question related to support. Will other support be required at the time of submission or at the just-in-time period?
Just the just-in-time period.
Yeah, okay.
So the bio sketch is required in the application. The support can come later.
See, so will there be a single IRB for the whole network? For example, across the MCD, is it multiple chronic disease centers?
I think that's really going to depend on the nature of the projects, what the region is, and yeah, so it's possible the same IRB could serve all the projects. It's also possible multiple IRB or different IRBs would be relevant.
I think the question may be getting at whether or not all of the awarded centers in the initiative itself would have a single IRB, not just a single IRB for all the projects within it.
Right. That's not the plan. The coordinating center won't have that kind of a role. So there won't be a single IRB for all the centers together. Do you agree, Dr. Stinson?
Yes, I agree.
Okay, thank you. Another question about the regions. So how far apart can the regions be? For example, can we have projects between Georgia and California or in Georgia and California?
Right. So the question that all the applicants need to answer is what is their region and why is it a region? And my cat is awake now, so you may hear. So what region, if you're including Georgia and California, why are you including Georgia and California? And what is that, how are you defining that region? So I think we're not looking for things that are really different, separate, and then saying, well, we're looking at multiple regions. We're looking for a regional approach because of some of the shared characteristics within a geographic area, whether it's contiguous or not. And so it's really up to the applicant to come up to identify a region that makes sense and to justify why a regional approach is really necessary to address these particular research questions.
Okay. So another question, can pilot investigators be internal or external to the applicant or applicant university?
Right. They can be both. They have to come, the requirement is they come from organizations within the specified region.
Okay. This is regarding the core. So without a statistics and data core, should P50 studies, P50 centers expect the coordinating center to supply information systems for data collection, data management services, and statistical analysis of data from R1 level studies or pilot projects?
So I'll take a stab and then I'll ask Dr. Stinson, who's the contact for the coordinating center. So the coordinating center is mostly for addressing the common data elements and data harmonization, not to manage data collection, storage, management across all the studies. The research projects are funded at the level of a typical R01, so there should be resources for the projects to handle those kinds of basic data functions within their budgets. Would you like to add anything, Dr. Stinson?
Yeah, I would just add that the coordinating center is primarily going to be a resource to the individual centers. It's going to play a certain role with the common data elements and harmonization of those. I would encourage everyone to take a look at the companion FOA that we have. That's RFA MD 21008. That's the coordinating center. And within that, it talks about the resource coordination and data analysis function that we have as expectation for the coordinating center. So looking at that may give you a good idea of certain aspects of what you want to include within your particular center.
All right, thank you. There's another question about budgets. I'll combine two questions. So is there a budget limit or guideline for the community engagement core? And similarly, is there a cap on the budget for the administrative core?
Right. So there's quite a bit of flexibility in how the centers are constructed. So there are budget limits for the research projects, and then budget minimums or ranges for the pilot projects and the number of pilot projects. Beyond that, applicants really have latitude to put the resources where they choose. So there aren't budget minimums or maximums for any of the other center components beyond those that I just mentioned.
Okay, thank you. Another kind of coordinating center question. Can you talk more about how centers are expected to work with the coordinating center?
And can I pass that one on to Dr. Stinson?
Could you repeat the question? I did not capture it.
Sure. It's just if you can speak more about how the disease centers are expected to work with the coordinating centers, with the coordinating center.
Well,
kind of
yeah.
Question.
All the details really have not been worked out about the specific role of the centers with the coordinating center. As I mentioned earlier, our idea is that the coordinating center really is there to be a resource and to kind of facilitate the collaboration and try to find ways to really create some synergy in what the centers are trying to are trying to achieve, with their specific aims and goals and objectives. In addition, it will play a role in the development of the workforce at the different centers, in that one of the components of the coordinating center really surrounds research skills development for investigators at the different chronic disease centers. So part of what we always like to do with coordinating centers, especially before we even know which other institutions are going to be part of any particular consortium, is to try to be relatively broad in nature as far as what our expectations. And once the coordinating center is selected and the individual centers, they would start a planning process of really delineating what the collaboration really should look like and how it would turn out to be most effective for all parties involved.
All right, thank you. Let's see, another question. Would themes/interventions that address multi-morbidity in general rather than two specific diseases be considered responsive to this RFA?
So we certainly welcome centers that are focused on multi-morbidity. You do need to identify what the chronic diseases are, two or more, because that's a responsiveness criterion. And so if you just say we're looking at risk factors that are for co-occurring chronic conditions or something like that without specifying specific chronic conditions that could result in your application being non-responsive. I'm not sure if I answered your question. You can let me know in the chat.
Okay, we'll monitor for that. Maybe similar to a question that we've already answered. Do all three R01s need to address both chronic conditions? Or is the expectation that thematically the center addresses both across projects and frames?
Right, so it does depend on what the theme the applicant selects for the center. But again, since we are looking for a focus on co-occurring chronic conditions or chronic conditions that share risk factors, etiologies, or treatment or management strategies with the goal of not doing fragmented siloed research. We're not looking for projects that I have two, we have two chronic conditions. One project will be on one will be on the other. You need to think about whether that meets the spirit of having this more integrated approach to chronic disease. We're leaving it flexible because some projects are really focused on the risk factors and prevention, and some are focused on treatment and self-management. So we don't want to over specify what the outcomes need to be, but you need to think about what will really sort of meet the spirit of a more integrated approach to looking at chronic disease disparities.
Okay. Another question. Is it correct that the applicant institution does not have to be in the region of focus for a center?
That's not correct. I mean, so there need to be two, we're looking for two academic or research institutions within the region to be part of the overall consortium. So,
okay.
Yeah.
Yeah, just be within the region. Okay. Let's see. We're getting a lot of different kind of
right. And I'd recommend a very specific question about.
Yeah, I think so, because we're getting.
Yeah, yes. You can contact Fabienne or me directly, and we could have a conversation about that. We want to avoid saying, yes, that fits, or no, that doesn't fit, or just some of these things may warrant a more detailed conversation.
Yeah, we're getting a few iterations of what a different region and center would mean. Let's see. Yeah, it's another one. So yeah, as Jennifer said, any questions specific to your thoughts on how you want to coordinate the centers and regions, please let us know or contact us directly. Okay, so I asked if anyone has any more kind of general questions regarding the RFA or the actual diseases and questions. Please let us know. Let's see. Okay, one just came in. Will all pilot projects need to focus on the same region as well? Do the pilot investigators need to be located within the region?
Yes and yes.
Okay. Any other more general questions? Once again, any kind of more specific questions, please contact us directly. You're very welcome. I'm getting a thank you.
All right, we can give a couple more.
Yeah, I think
If there are any more
a few more
questions?
minutes. Yeah. Lots of thank yous. You're very welcome. Thank you for listening and for your attention. Oh, we got a mahalo. Thank you. That's nice. All right, so lots of thank yous coming in. So I'm going to take that as we've pretty much addressed the majority of kind of big buckets of questions. And I guess any further thoughts from you, Jennifer or Nate or Marilyn, before we close the meeting? That's okay.
Just thanks for attending the webinar, and feel free to contact any of us if you have any questions moving forward.
Okay, well, I guess that's it then. Thank you again. And please, as Jennifer mentioned, let us know if you have any questions.
All right, thanks everyone.
All right, take care, everyone. Thank you.
Thanks, everyone, again. Take care.